Good afternoon, everyone, and welcome to today's webinar, Ensuring Health Across Rural Minnesota in 2030. Today, we'll be presenting the methodology, summit findings, and policy recommendations from an important study conducted recently. I'm Sally Buck, a CEO at the National Rural Health Resource Center, and my role here at the center is primarily oversight of federally funded rural health programs and provided oversight on this study. I'd like to have the other speakers introduce themselves, and so you know their faces and names and voice before we get started. And I'll start with Terry Hill.
Terry Hill, I'm currently the Senior Advisor for the National Rural Health Resource Center.
Marcella
De La Torre, I'm an adjunct professor at the College of St. Scholastica.
David Mark.
Hi, everyone. My name is David Mark. I'm an associate professor in the Department of Health Informatics and Information Management at the College of St. Scholastica.
Well, through our session today, we'll be presenting the study, and then we will take questions at the end, either in the chat box or by asking through your audio. And first off, I'd like to recognize our project partners and contributors. And with funding from the Mayo Clinic Foundation, the National Rural Health Resource Center, the center, partnered with the College of St. Scholastica in Duluth and Strawwater Associates to conduct this study that examined the trends and disruptors within the rural healthcare environment, and these that will influence access to affordable quality care across rural Minnesota in 2030. Our project team brought together a range of expertise in rural health, healthcare quality, data analysis, data modeling, financial modeling, value-based and historical fee-based payment models, also research, leadership, facilitation, and group process design. The goal for this study was to provide a framework for planning that's been informed by data and illustrates the interacting components of health, provides scenarios for forward thinking, looking ahead 10 years, and finally identifying options for rural health policy development in Minnesota. All right, and I will turn it over to Marcella to talk about the first component of the study, which was a literature review.
Thank you, Sally. I didn't realize I was muted earlier. Got started. An extensive literature review was conducted by the project team as a starting point to better define the scope and content of this project. The full review is included in the Appendix 3, including all references. After careful review of the resources and discussions with the project team, several trends and disruptors were identified. This work provided a framework for testing some of the assumptions that we had made and discovering new information. A trend is usually understood as a general direction in which something is continuing, developing, or changing. And you have the trends here that we identified: increasing diversity and aging population, increasing healthcare costs, expanding connectivity and broadband access, continuing integration of technology into healthcare solutions, increasing partnerships, networks, and mergers in healthcare, continuing shortage of workforce in our healthcare system, progressing toward integrated behavioral health with primary care, and recognizing the impact of social determinants on health and wellness. Later in the project, the trend and disruptor themes were used to design the Rural Healthcare Summit, and participants were provided the literature reviews preparation for summit discussions to ensure uniform and shared understanding of the current state of healthcare. Disruptors are events that can affect current trends, require changing thinking, and alter how we respond to or participate in change. And we have them here as well. Healthcare consumers focused on lower cost and convenience, innovation and value-based payment models, drive new care models, new technologies are supplanting and supplementing traditional care services. Financial pressure is impacting decision-making and the future of healthcare facilities. Changing roles are providing care in new ways, leading healthcare as a complex and adaptive system in global integration and interdependence. Finally, the trends and disruptors informed the design of the summit and were a starting place for discussion within the 4 case studies that we'll see in just a few seconds. And also during the summit, participants assessed each of the disruptors by estimating the likelihood of occurring and the effect it would have on access, affordability, and quality of healthcare. And I think David is going next, correct?
Back to me. And looking at the current trends and trying to look ahead, we knew that a cookie cutter solution was not going to provide long-term solutions. So the model that was taken for the study was developing case studies, and this was at the suggestion of Mayo Clinic. And they wanted us to look at the potential of these trends over the next 10 years and the impact of the disruptors. And through data analysis, there were 4 case studies developed from combining data of different regions of the state. So we started with Delta Lakes, and that represents a community with a diverse economy, a local healthcare facility that is a critical access hospital that's independent and partners closely with a regional health system. And that included primary care, long-term care facility with a memory unit, small surgery, and emergency department. Then in Northeast Minnesota, our case study was Charlie Pines, and this represented a small community that's quite isolated with a local critical access hospital, county-owned, long-term care and emergency department, but a facility without OB-GYN services or surgical services. And 74% of the revenue of Charlie Pines is actually outpatient service. Then Bravo Perry represented the southwest part of Minnesota, and this was a community with changing demographics, a local 48-bed hospital, and this was owned by a health system, many specialists working full-time at Bravo Perry facility, and additional specialists employed by a system who visit on a regular basis. Surgical services and emergency care, home care, hospice. Then over in Alphaville, this represented a community that's growing and influenced by the metropolitan area and local healthcare owned by a health system as a critical access hospital with an emergency department and partnering with independent primary care clinics. And this composed our 4 case studies that allowed the discovery of trends as we were looking at the environment and how that would impact communities of different sizes and also hospitals of different sizes, and gave us a framework for finding the recommendations for policymakers. And we have more partners in the study. And as Marcella noted, we held a summit, and that was held virtually, but it convened a number of rural health leaders with diverse roles, perspectives, and expertise who shared their knowledge and insights. And this was really an integral part of the study. And our representatives, you can see, were primarily from Minnesota, but we did have some participants with a national perspective as well, from the National Rural Health Association and Stratus Health, working nationally, and also the National Governors Association. And the representatives provided us their perspective, be it in quality, policy, healthcare delivery, administration, technical assistance, and research. And they really were key to guiding the identification as we go through the findings here of key disruptors, likelihood of them occurring, and recommendations. And we want to acknowledge their contribution to the study and thank them for sharing their expertise and their time throughout the project. The summit participants first identified a vision of a healthy rural Minnesota. And these were the key items identified in that visioning exercise: care for illness and wellness, providing care that's oriented around the community member, whole person care, cradle to grave care, seamless data sharing, partnerships across the sectors, and affordable to all community members. And the vision truly was our beacon throughout the study and guided our decisions as ideas were transformed into different modeling and processes. And Terry's going to walk through the trends that were identified at the study.
Right. And what we found here, I'm not going to go through every one of those because Marcel has already talked about the ones we found in the literature. The trends identified by our participants largely aligned with the literature review. So we saw, greater access to broadband and a number of different things here that helped us kind of identify which way to go and kind of we're in a association with our vision. The trends here, as we defined it, is our general direction in which something is continuing, developing, or changing. Next. The disruptors, let me talk a little bit about those. So the disruptors are going to influence the trends, and the disruptors, we're defining it here as an event that can affect the current trends. It could require a change in thinking, and after how we respond, it could really alter how we respond to or participate in the change. It could change the trajectory of the trend. We could be moving in a particular direction. The disruptor happens, and then we're going to be altering that direction. So we looked over the next 10 years. Is it going to move us towards the future vision of access to quality and affordable care? Next. So these were some of the identified disruptors. Consumer-driven options to access healthcare. We saw this as a potential disruptor. It's obviously a trend as well, but depending how it plays out here, it could very well be a disruptor. We're going to see a more dramatic focused social investment. We're going to see an increased intention on rural health vulnerability. I think we've been seeing that in the last few years, and we expect that's going to be something that's going to continue. We're anticipating some innovative rural population healthcare and payment models. We just saw a brand new one called CHART, and that is going to actually perhaps disrupt some of the trends that our rural hospitals and clinics have been moving in. We're going to see new technologies integrated into healthcare. And particularly 2020 has seen an acceleration of that movement of these new technologies. And then we're going to see telehealth technology, payment, and regulation changes. And that is something that, again, we're seeing here in 2020. Next. So I'm going to turn this over now, I think, to Dave, who is going to talk a little bit more about this.
Thank you, Terry. So during this project, we did hold a summit to gather insights from participants, rural healthcare leaders across Minnesota, to get an understanding of the likelihood and the impact of these disruptors. The findings from that summit included a variety of different things. First, there was high level of agreement across the summit participants that improved access to rural healthcare is most likely to be influenced by 3 of the disruptors. And that includes consumer-driven options to access healthcare, dramatic focused social investment within rural communities, and telehealth technology, payment, and regulations. In addition, there was a high and moderate level of agreement with regards to the summit participants that improved affordability will be influenced by these 3 disruptors, and they include a dramatic focused social investment within rural communities, new technology integrated into healthcare, and also telehealth technology, payment, and regulations. Finally, there was a high level of agreement amongst the participants during that summit that improved quality will be influenced by one of the disruptors, and that is dramatic focused social investment within rural communities. Now, these insights that we gathered from summit participants of predictive and anticipated influence of the disruptors was integrated into developing some recommendations from this project. And along with that, the data that we gathered from the summit participants, we did look at other data sources. So we looked at historical data to get a sense of the trends in various metrics related to healthcare outcomes, to estimate the health of rural communities in Minnesota in 2030. So we used historical data to make a prediction of what the future will look like. And the results are included in the report. It's in an appendix and also in table 5. And in the report, the data that we used, you can see, is from the county health rankings data. And it was analyzed using a approach to use a multiple regression model to perform a trending analysis. And based on the trends identified by the summit participants, backed up with the data that we used from the county health rankings data, we observed that there are some metrics that suggest progress towards our vision for 2030 for healthcare in rural Minnesota. 2 trends that summit participants identified as important to watch and to work towards influencing over the coming 10 years are a focus on social determinants of health and access to primary and mental health care. Now, there are several metrics that to watch as indicators of progress towards the vision for 2030. And some of these are showing positive trends, and these include a decrease in unemployment, uninsured rates, and the rate of children living in poverty, increased attainment of levels of education, increased median household income, and an increase in the ratio of mental health providers based off of population size. There are also several metrics to watch as indicators of progress showing potentially unfavorable results into the future. And those include an increase in the percentage or rate of the population that reports poor or fair health, measures related to physical inactivity, and also a metric of excessive drinking rates, which could be related to unhealthy living choices. There's also unfavorable trend with regards to the decreased rates of the population that receive mammography screenings. So collectively, these metrics can be used somewhat as like a guidepost while policies and projects are implemented across the state. So that could help assist leaders in using these metrics as a way to monitor our progress towards the vision of what we are hoping for rural healthcare in Minnesota in 2030, and making some adjustments to those programs using these metrics as a guidance. And I'm going to hand it back over to you, Terry.
Thank you. So in this model, because we started with this vision of where we were going into 2030, finance follows both form and function. So as our Stroudwater partner says, we want to have a payment system that pays for the functional imperative of the system and the form that's put into place to achieve that function. Well, that's translating that to our study. Our vision drives us to ensure affordable, high quality care. And that in turn influences us as to how to deliver that care. And that in turn directs our financial system to pay for the care that we want. So this finance follows form and function is kind of central to what's going to follow here. And it provides kind of a framework for us to move forward. The financial model recommendation actually comes out of our financial trends, and particularly our Medicare reimbursement for rural. There's a very definite movement towards a global budget form of payment. That global budget basically was just a huge incentive, and new programs were developed just in the fall of 2020. And the global budget itself is anticipated to produce shared savings. And those shared savings, so lower costs, we're gonna be able to provide high quality care at a lower cost, and those shared savings themselves will provide a mechanism to invest in our community's health. Now, these are the key financial model assumptions, and these were developed by our Stroudwater team. First of all, a local healthcare inflation factor of about 3%. That's pretty much been what we have seen over the course of other models, the other Medicare models. Our fee-for-service reimbursement price increase, we're going to hold that down to about 2% annually. And our fee-for-service utilization growth we see at 0%. In other words, we're going to do less or at a very minimum, no more than what we're doing already under fee-for-service. Our attribution population, those assigned to us by the payers for our all-payer cost-based payment system, we've modeled out here at 90%. And the total service population and yearly growth are going to be unique to each of our 4 cases here, based on the data that we're already seeing. We're going to have a global budget annual increase of about 3% as well. In the modeling that's been done in some of the previous models that CMS and our Medicare payment have seen, 3% seems to be an acceptable rate. Our shared savings activity is going to start at 3%. In other words, we're going to start low here at about 3%, and we're anticipating increasing that to 12% over the 10 years. And I think based upon the value-based payment models that we have seen in the past, our rural networks and our rural models are capable, we think, of basically producing those results. In this particular model, because again, we have this vision of better health for our participants, we're going to take 50% of those shared savings and invest them into health and wellness activities. So those are the assumptions that are going to produce the results we're going to talk about here. Okay, so if we continue in this fee-for-service model, so we've got our 4 models here, and what we see under current is that one of them, Delta Lake, is in the net margin right now. Their net income is at positive numbers. Our other 3 hospitals, however, are in negative numbers. The anticipated, if we continue the trends that we are seeing, and this is all based on 2019 data, if we have no change in the payment system, we continue everything as it is, we see that we're coming up with some really negative numbers, and Bravo Prairie in particular is at negative 13. And that is going to be really, really difficult to be able to sustain itself over time. We have real, Delta Lake continues in positive territory, but just barely. And we're seeing negative numbers big time in the others, particularly Bravo Prairie. If we put in this global budget with shared savings, we see that every one of these hospitals improves. And we also see that our projected investment in the community health and wellness is also available to make some of the changes in some of the health and wellness initiatives that we're going to need here. So,
Thank you.
Sally, I think it's you.
Yep. Thank you. We then looked at the priority disruptors, and this came from the summit. And again, a disruptor is an event that can affect the current trends, maybe require a change in our thinking or a need for policy change to alter how we respond to the change. And of all the disruptors that were identified previously, these 4 were risen up as really key that our summit participants felt that without intervention, specifically for rural, that these disruptors were not likely to happen. And those included an innovative rural population health model, such as the one Terry just presented with the global budget and shared savings, that is truly designed around a rural service area and low volume and population, an increased attention to rural health vulnerability. And we have certainly seen that in the COVID-19 pandemic, that there have been a number of initiatives focused on rural, recognizing that vulnerability, both for the population, but also for the continued sustainability of healthcare delivery. A dramatic focused social investment within rural communities, and telehealth technology, payments, and regulations. And overall, the summit participants had the highest level of agreement that the third one, the dramatic focused social investment within rural communities, that would have the biggest impact over the next 10 years if there was the needed intervention to spur that on. And the recommendations based on those 4 key disruptors that summit participants identified were expanding the investment and collaboration between clinical care, public health, and community agencies, providing models and funding for preparedness collaboration, including data sharing and public health, transitioning to value-based payment structures that do share revenues and moderate risk and improve health, and continue critical access hospital reimbursement and other safety net programs for hospitals, rural health clinics, community health centers to ensure rural access. So these recommendations are again keyed off of the disruptors that were most likely to need rural intervention. And risen up as recommendations for policy makers and stakeholders to focus investment of time and resources. We then brought together all of the information from the study, everything from the literature review, data analysis of the case studies, and the financial projections to our 4 case studies, as well as the modeling, and developed key policy recommendations with the input, certainly from a state perspective, from our Office of Rural Health and Primary Care, and nationally with the Rural Health Association. And these recommendations include ensuring access to telehealth, home monitoring, and other emerging technologies in healthcare, creating policies and payment structures based on outcomes, including quality, patient experience, and efficiency for non-traditional sources, focusing social investment within rural communities to address health disparities and build community connections, addressing rural health vulnerability, especially in response to the impact of the COVID-19 pandemic, with a greater collaboration to ensure pandemic preparedness, effective response, and financial recovery. And finally, expanding innovative and flexible rural population healthcare and payment models to address financial pressures, promote population health, and ensure viable health services within rural communities. So this study, in its total framework, informs rural health stakeholders of the key trends and disruptors that influence access to affordable quality care across rural Minnesota. And with the demographic and financial modeling out to 2030, you can see what is needed to ensure that vision of health. The key disruptors identified and presented with the key policy recommendations reflect that multifaceted framework of methodology based on the case studies and modeling. And also, we've included a number of references for future work and application to other states. The final report also has accompanied appendices that detail the project team, summit participants, the methodology that was used, literature review with all of the references for the identified trends and disruptors, the community profiles, and the detailed case studies of those 4 profiles with demographic, workforce, census information, and also the projection out to 2030 for those communities, as well as the financial model and recommendations and the methodology behind the financial model. And there are accompanying videos of the financial modeling presentation, as well as the summit recommendations. So we encourage you to visit the center website and to review the full report and appendices, and to consider these important policy recommendations in your work in rural health, whether that be Minnesota or nationally. And now we'll open it up for questions. And Keely has posted a link in the chat box to the full report and appendices. we have any questions or comments?
Yes. Hi. Can you hear me? This is Rhonda Deglow.
Yes. Hi, Rhonda.
Hi, Sally. First of all, I just want to thank you and the project team for an amazing piece of work. I mean, this is really incredible. I read it pretty thoroughly, and I was just really taken by the, you know, all of the work and thought that went into this. And I guess my question is, what do you envision now as far as next steps in getting the policy recommendations in front of policymakers?
Yes, thank you, Rhonda. I'll start the answer to that. And then I see some of our colleagues from Mayo Clinic are also on the line and are leading the Minnesota policy recommendation dissemination. But nationally, with our summit participants, we have shared the report and recommendations, and the National Rural Health Association is looking at how these align, certainly in going forward into the next Congress. And Brock Slaybog, who's the Vice President, Member Services at NRHA, and they will be considering these, especially the recommendations that are brought forward are not, I guess, they're definitely applicable to our Minnesota communities and our case study profiles. However, you can see in the language that they're very much applicable to rural communities as well as facilities nationwide. And either Randy, would you or Kate want to comment on the rollout with it to the Minnesota legislature?
I can start and Kate can jump in. So one, Sally and Terry and the folks at St. Scholastica, on behalf of the Mayo Clinic Foundation, we really want to thank you for really doing a really strong and deep study into the needs in rural Minnesota specifically. For us at Mayo Clinic, my colleague Kate Johansson, who works at the state capitol, will be using the study to really elevate the needs that rose to the top in the study among legislators and other policymakers in Minnesota. But just also to pick up on what you were saying, Sally, we will also use it at the national level as well to some of the things that we're really looking at in the near term hopefully the wake of the pandemic is really to see both state and federal regulators continue the flexibilities that we've seen during the pandemic, the national health emergency for telehealth. It's really increased the use of telehealth both by our providers as well as by patients, and the value of it to our communities is great. It doesn't replace an in-person visit by no means in our rural communities, but it is a valuable source of getting subspecialists to see patients in rural areas. So we're going to really prioritize work in that area and increasing broadband infrastructure as well, just to name a few. I don't know, Kate, if you want to say a few more things.
Yeah, happy to. Thanks so much, Randy. You know, to that point, as Randy mentioned, we are planning to share this presentation with a variety of lawmakers the week of December 7th. I think actually the Friday of that week is when we're planning to reach out to them. We've already released the study to all of the legislative partners with whom we've worked on rural health issues, and frankly, a broader policymaker audience within Minnesota. and let them know that they'll be invited to that presentation. We're also looking for ways to incorporate the findings and recommendation of the study in our one-on-one outreach. There are several new lawmakers this year, as you likely have noticed. There was an election a couple of weeks ago, and there's not only a new legislature, but also several new members who will be interested in this issue. And we've reached out to them to connect with them, and we'll be using this when we talk about them and their concerns with rural health as well. And then lastly, you know, as the session progresses, we'll use this report as a resource when lawmakers come to us to try and understand some of the problems that their constituents might raise with them specific to rural health. So those are a few of the ways that we're looking into it. Now, certainly you can't solve every problem. I once had a lawmaker ask me how many defibrillators they should have in their house, and I didn't even know where to start with that one. But you know, certainly we'll be able to use this on a variety of great rural policy issues that we anticipate coming up.
Thank you, Kate.
Just another comment, Sally. First, I want to acknowledge Mayo. This has never been done before. Sally and I and Rhonda have been around quite a while, and we have a really pretty much a comprehensive view of everything going on in rural health right now. So the very thought of trying to predict where the industry is going to be going and where healthcare is going to be going in 2030 is a huge undertaking, but I think it's an extremely important one as well. So I think we've had a tremendous amount of interest being shown by other state offices of rural health, hospitals, et cetera. And I also believe that the financial model that's projecting here nothing like this has ever been done before. And I think it's an extremely sound model. The major new program that came out of CMS recently actually is a global budget model, and that was after the our model was put into place and after our summit folks met. So this is going to be, I think, have national significance, hopefully to Mayo, but also I think to other states and other rural healthcare providers as well.
Thank you, Terry. And actually the telehealth policy recommendations, a number of those were reflected in a policy position brief just adopted this week by NRHA. So we are seeing it certainly at a national level, an interest in the continuation of the flexibility and the regulations for licensing providers to allow telehealth to occur across state lines and for the payment of services. And I know in the chat box, there's a question from Joe Schindler at Minnesota Hospital Association. The question is, was there any measurement of Minnesota rural hospital readiness for moving forward? And that's an excellent question, Joe. We did not assess readiness of specific hospitals since we were developing the modeling and projections based on a case study. We did have hospital leaders, 3 physicians and 2 administrators of hospitals and clinics on the summit panelists as well. It certainly would be a key factor we see in the movement towards value and population health, looking at readiness to move into risk, which we know is very difficult for rural facilities given their financial vulnerability, and also the need for collaboration and community partners. We do have a couple assessments that we currently use through our federal programs, a population health readiness assessment and a critical access hospital performance excellence readiness assessment, which are 2 key parts, but both the risk level for finances and the need for technical assistance is often what we see to get through that transition. As we saw in the financial modeling, it took a number of years even to move through that. And Terry, do you have any other comment?
I do. That's an excellent question. And what we see nationally, because we work very closely with 45 states and their critical access hospitals in particular, is that Minnesota is probably more prepared than other states because they've had a pretty high participation in accountable care organizations. The state has instituted a number of kind of value-based payment models moving forward. We also have been able to kind of anticipate what the hospitals are going to have to go through moving forward, the development of care coordination capabilities, the focus on the social determinants of health. It evolves over time. And consequently, we projected, based on the evidence that we have seen nationally, that 3% was an achievable goal in the first year. And that in essence, once those investments are made, we could move up to 12%, by the end of that 10th year. That's all speculative, actually. But we do see, for example, that the performance of our accountable care organizations and our other value-based models has been greater with rural hospitals and clinics. I don't think that's necessarily surprising. They're smaller. They're more maneuverable. They can change quicker, et cetera. And so we think the dynamics of all of this indicates that it'll vary in terms of the readiness itself, but we feel optimistic that Minnesota in particular is ready for that challenge. Other states, particularly states that have been pretty much a lot of independent hospitals, aren't aligned with healthcare systems. I can give you Texas, for example, about half their hospitals are still very, very independent. They're going to have a more difficult time, I would think, and would be less ready to make this move than Minnesota would.
Yeah, thank you, Terry and Sally. I think those are good assessments, and I appreciate the study. This is helpful in putting all this information in one place. I know that global budgeting has been in wide favor the last couple of years, especially since Pennsylvania is experimenting with it. So I'm hoping that we'll see some pickup. I know we've had some discussions with the state, and there is some interest there. So I think, and you're right, we have the spectrum. Probably we're further down the spectrum for many of our rural hospitals, but like you mentioned, there's a lot of rural independents that we're also working with to try and find a pathway for them to move down the path so they're ready for this change, which probably will be less than 10 years from now, but with any luck, actually, because as you can see from the financial modeling, it's probably a more sustainable method for maintaining access in rural areas. So thank you for the study.
Thank you, Joe.
Thanks, Joe. Great. Well, thank you all for joining us this afternoon before the holiday. And we encourage you to distribute the report and findings and certainly the recommendations to others. We know that's how the change will happen from not only a policy perspective, but also within organizations and community level. So have a safe and healthy holiday, everyone.
Bye, everyone.
Thank you.
Thank you.